and welcome back to another episode from Across the Table. Today's guest is someone deeply committed to improving the health and well-being of our community. Dr. Reena Virdi is a general practitioner at the Primary Care Centre, a well-woman clinic doctor where she focuses on supporting women through various stages of their lives. Thank you for joining me.
Thank you for having me.
A little bit of an introduction. It's a tradition that I have on my podcast. So, beyond your clinical work, you're passionate about healthy living, conversations around topics from lifestyle habits to menopause and workplace well-being. Her approach blends medical expertise with compassion, practicality, and a real understanding of community health. We'll get into the journey now of how you started menopause, which is the main focus of this episode. But just let us, why did you want to become a doctor?
Okay, so that's going back a little while because I've been a doctor for about 14 years now. It all started at school. I was watching a lot of TV on, the non-reality shows of hospital and A&E, and they're not really representing real life doctoring, but it was really interesting, and I think I really was drawn to the chaos of being a doctor. So I did some work experience. I really enjoyed that. That was in West London at the time. And then, I went on to go to medical school. GP, I wasn't sure I'd want to become a GP because I had a few other things in mind, but that's just seemed to be the pathway that I went down, and no regrets. I'm really enjoying it.
So it wasn't everyday drama like in the series then?
Not quite, no. But it's the chaos is definitely there. Yeah. So it's more like organized chaos as a GP. It can be a bit more chaotic chaos in an A&E department, for instance. But it's always the unknown. You just do not know what's coming through your door every single day, which is quite exciting. Yeah. It's a new challenge. Every day. Exactly. Yeah.
So today's one really want to focus on is menopause.
Okay.
Which affects half the population, and for decades it's really been misunderstood. I know lately we've become better and better at it. So we'll just get straight into it. What is menopause?
So menopause is that transition for women between having their regular periods to them slowly starting to change, becoming less frequent, maybe a bit erratic as well, to then eventually stopping completely. So when you've achieved menopause, it's 2 years of no periods if you're under the age of 50, and 1 year of no period if you're over the age of 50. That would be the menopause status.
So the difference between peri then and menopause, I'm not the expert obviously, so that's why I'm asking you.
No,
so these terminologies that I hear. So peri then to menopause, what's the difference then?
So the perimenopause stages that lead up to menopause. Okay, so the perimenopause would be when your periods are starting to change, your symptoms are starting to become more apparent until you've achieved that 1 year of no period or 2 year of no period status. So anything between that is your perimenopause, and that can be anywhere up to 10 years. So it can be quite a long time until you actually achieve the menopause.
Is there a jump? Is there like a line in the sand that says, okay, now you're in menopause from peri, or not really, or is it?
It's just that marker of no periods. So once you've not had a period for an entire year over the age of 50, or an entire 2 years under the age of 50, that's it. That's the clinical diagnosis. Some women think that they need a blood test to know, but actually that doesn't matter. It's always a clinical diagnosis. Albeit you cannot be on any hormonal treatment whilst you're assessing that. So it would have to be without any contraception or any kind of hormonal treatment. So it's if your natural periods come to an end.
Okay. So the biggest misunderstanding then, because it's good to have this information. So what's the biggest misunderstanding about menopause? From a male side point of view, and for a female, more importantly the female side, what's the biggest misunderstanding there?
I don't think there's many misunderstandings. I think some women can really dread it. Some women really don't want to stop having their periods because that's what they've been used to for the majority of their life. So it can be a big life change for a female. Some will think you need a blood test or you need to have some kind of check done, and that's not necessarily the case. It's really about the symptoms that develop and how much they bother you. But otherwise, there's not really a misunderstanding.
So what are the symptoms then? And the early warnings that maybe some women do forget as well, that it's happening to them, but they're just like, that's not that one.
Yeah, so there's such a long list of symptoms. It literally goes from so many symptoms. So you've got your typical hot flushes and night sweats, and then you've got your brain fog and tiredness and forgetfulness. And some women can get quite emotional, so tearful, low mood, anxiety, sleeplessness, muscle aches, joint aches, itchiness of the skin, palpitations. There's some things that we don't really realize are menopausal symptoms.
Yeah.
And sometimes women can present saying that actually I've got this problem with palpitations, for instance, and I think I need more investigations. And often as a GP, we would then think, oh, okay, it needs a cardiology review and it needs an ECG and it needs bloods. And actually that alone can be a symptom of menopause.
Just that single symptom?
Yeah, I've seen that before. So it can sometimes be that just one or two of the symptoms are apparent, or it can be that all of them are there.
Yeah.
So it's just such a range of symptoms that women can have. But yeah, the list goes on. There's quite a few.
I can imagine. But it's not so when should women seek help then? Just from that one symptom, or would you recommend more of those symptoms are present before they...
I think the real question would be, how much is it bothering you?
Okay.
Sometimes these symptoms are manageable. Some women will have a few hot flushes, they'll have a bit of brain fog, but it's not bothering them. They can still function day to day, they're still happy, they're still getting on with things. If it becomes troublesome and it's bothering you, that's when you'd need to sort of look into, okay, what do I need to do next? Yeah.
So bothering as in you go into a room and you forget what you want, or is it like you're getting frustrated with yourself saying,
well, bigger things. So yeah, so when it's affecting your ability to work, your relationship with people around you, your happiness, they would be the sort of things that are more extreme bothersome. But even if it's just hot flushes that, it is bothering you day to day, you can't find the right clothes to wear, you're finding yourself feeling uncomfortable day to day. So it in terms of how extreme it is, it can be, a range. But it's just if it's enough to bother you, like anything else in medicine, if it's enough to bother you that you feel that you need to go to the doctor, then that's probably when you do need to speak about it.
What's happening through the brain during menopause? What changes are happening in the brain then?
That's a good question. We don't actually know what's happening to the brain for us to get for women to get the brain fog. We don't actually know what the mechanism is behind that, but I think it's something to do with the hormones changing, and that then leads to that brain fog. So you do just have those moments of not knowing what you were about to do, or what appointments were there for the day, or what day it is. It can be quite bad. So we don't actually know what happens to the brain function, but it is just something to do with the fluctuation of the hormones. And there are ways to try and manage that, by keeping a diary, keeping notes on your phone or notes around you so that you remember what's going on.
Post-its everywhere.
Post-its everywhere. They're usually quite useful. Reminders. So there are ways around it, but yeah, we don't quite know why that happens with the brain.
And the confidence then it must affect women. Massively.
So the confidence can be a really big, one of the key things. I mean, for a female who may have been high functioning, working in a high career, with children, with family she's looking after, and then to suddenly have all these symptoms come on where you can't function to your best ability day to day, of course it will affect your confidence. Yeah. You've gone from being this superwoman to feeling like you can't cope, or your relationships are maybe taking some strain. So of course it would affect the confidence depending on how much it's affecting you. So yeah, if you're not aware, it can really sort of weigh you down until you actually realize what's going on.
Is that the biggest one for women? We were saying about seeking help is because they don't want to admit that that's going on, or is that an unfair assessment from myself?
No, I do see that. I do see women coming, having tried to put up with these symptoms for a while, and then realizing this could be menopause, or that no, I can't cope anymore. So it may have been manageable to begin with, and then it kind of creeps up to the point that they can't cope. So they do often present with I didn't realize this was menopause, or now it all makes sense, and that kind of light bulb moment.
And they lose themselves, don't they, as well? The feeling that they've lost themselves.
Yeah, I mean, if you've got strained relationships with your partner, with your children, with your friends, if your work's being affected, it will affect your well-being completely. Yeah. So yeah, you some women will start to feel really quite low with it, to the point that actually they'll present with what they think is depression or anxiety.
Oh wow.
And actually we haven't maybe looked at all the other symptoms or thought about menopause. So it can sometimes be diagnosed, as a depression and anxiety, so alone, without it being menopause. So yeah, it can really affect women.
And they don't even realize it, then they just think it's depressed about something else, and it's really...
Yeah, exactly. And I see that a lot. Women won't always think it was down to the menopause, and they think the tiredness is just normal. They think the sort of fatigue's normal, and joint pain's just part of aging. And yeah, sometimes you do think it's just part of aging.
Yeah.
It's not down to menopause, but yeah, a lot of them.
Or
can be.
exercise as well. You might have had a hard day of exercise. You've gone for a run. You've gone for this, and your body starts to ache,
Yeah,
and you're
of
tired. You
course.
think that's because of the
It's because
exercise,
of the
but
exercise.
really,
Yeah.
it's because of the change that they're going through.
Yeah.
So the estrogen level, and I'm going to read this one, the progesterone levels.
Yeah.
What's actually happening there then?
So these are the two hormones that women produce, estrogen and progesterone. You said it perfectly right. They start to fluctuate and decline beyond the age of about 40, 45. Okay, so that's when they start to fluctuate and then decline. A lot of these things depend on what age your mother was going through menopause. That's usually a good indicator of when you might start to expect these changes to happen. But like we said earlier, menopause can be much later. So you might start to see symptoms, from the age of 45 or even beyond 40, but you won't get menopause until a lot later. So that's when those hormones are just fluctuating. They're going up and down, and that's causing this up and down of your symptoms. And we'll go on to talk about it. That's where treatment can help to just stabilize those two hormones.
Should they get tested before? So levels like before and after?
That's a really good question, because that is what a lot of women come into to see the GP for, asking for a blood test. Blood tests are not helpful whilst you're still having periods, because your body's already naturally showing an up and down of your hormones. Our cycles are always going to cause an up and down of those two hormones. So if we take a blood test, we won't quite know what that's showing, because we might have caught it in one part of the cycle as opposed to another part of the cycle. The numbers will be completely different. So it won't really tell us anything.
So it's not a bigger dip because they're going through menopause than during their normal cycles?
That's a very difficult thing to figure out from the blood test. So a blood test is not helpful to assess that. The only time a blood test can be useful is if you were already on treatment and we may need to monitor it, or if we really wanted to figure out the menopause status in terms of need for contraception. So blood tests are not useful. They're not the diagnosis. It's always the clinical symptoms. So we will go through the whole history, the whole symptom list, to figure out if it's seeming like perimenopause or menopause. Otherwise, bloods will not be helpful for the hormone levels.
Wow. So it's a conversation really. They should need to come in, have the conversation with you, and you just relaying off what they're saying.
Exactly. Or getting information online, because there's a lot of information that women can get themselves these days to see where they are.
Yeah. So HRT then is what we're leading on to now. Who should get it, who shouldn't, to start off with, and then the benefits of it for women going through it.
Yeah, so HRT is hormone replacement therapy. So these are essentially your progesterone and your estrogen replacement. And they are usually body identical, meaning they're matching what the body would produce as closely as possible, which has actually transformed quite a lot in the last 10 years, because about 10 years ago we were using a very different form of HRT, which wasn't as safe and it was more synthetic. So now we've got more of a body identical HRT, which is very good. That's very good development of medicine. So in terms of who should take it, I usually go through a bit of a stepwise management plan with women, with my patients. So the first things you should always be looking at are your lifestyle factors, okay? So the lifestyle factors being, are you in a healthy weight range? So there's a body mass index that we use. I don't know if you've heard of the BMI, the body mass index. That looks at your height and your weight, and it gives you a number. If that number is too high, it means that you're classified as overweight. So if you are out of range, then you've got to try your best to bring that down, which we can go on to shortly. Then you also have your alcohol intake. So some people won't realize, but the alcohol but the limit would be 14 units in a week, and that's for male and female patients. So that's not actually a lot. 14 units is a bottle of wine and a bottle and a third of wine. Yeah. So that's it in a week. So some people may not realize that having the 2 glasses every night or binge drinking at the weekend is going over that 14 units per week. Then we look at the smoking status. So smoking won't be helping your symptoms. It won't be helping anything. It's increasing disease in general. So that's something to stop if you can. And then we look at your exercise levels. So if you are not exercising, that's strongly encouraged. So that's doing sort of maybe 3 days a week of high intensity training for about 45 minutes. That's usually the recommendation. But also making sure that you're muscle training and strengthening your muscles, because for women in particular going through the perimenopausal stages leading up to menopause, your metabolic rate slows down, which means your muscle mass turns into fat.
Yeah.
And then often women getting into that age range will say, oh, I'm finding that my fat's building up in places I don't want it to, around the tummy, around the waist. And that's because the metabolic rate is slowing down. So then to counteract that, you'd be strength training. So you'd be trying to build on your muscles and convert that fat back into muscle. And eating more protein would help with that too. So, and then going on to the last thing with the lifestyle factors is a diet. So making sure that the diet's well controlled, that you're having plenty of protein, enough fruit and veg, and less processed food, less sugars and less fats. So first we work on those lifestyle factors, okay? And if they're all as good as they can be, and a patient has tried their best to, cut down the drinking, stop smoking, reduce their weight, exercise more, improve their diet, and they're still struggling with symptoms, then we will be thinking about HRT. So HRT is more for women who have tried all the lifestyle factors and it's not working and they're still struggling with symptoms, and then we can think about HRT.
So it's so HRT is really like a last resort? Or is it wrong to classify it that way?
Maybe not a last resort. We can often try it alongside someone trying the lifestyle factors. But if they haven't got everything else in check, and obviously that's strongly encouraged, so they need to improve those lifestyle factors. But yeah, if it's safe to do so, then we can start the HRT. And there can be some patients who cannot take HRT, unfortunately. That's where you would need to speak to a clinician whether it's suitable for you or not. For instance, if you have had a history of breast cancer, then it's quite unlikely we'd give the HRT, because there is a small link to breast cancer.
Okay.
So, and if you did have a very, very high risk profile of, all the unhealthy lifestyle factors and maybe other things, then it might not be suitable. So it does very much depend on every individual and their risk factor and their risk factors, whether the HRT is suitable.
So a lot to unpack on that one there.
Yeah.
So why, go back to the beginning of the HRT point, why did HRT have a bad rap at the beginning then?
Because it used to be, like we said, a synthetic form. And it used to be given solely as a tablet. So you used to just prescribe the tablet form of it. Now that had risks of clots, of blood clots. And that's risk in itself. If you suddenly have a stroke, which could be life-threatening, or leave you in quite a bad way, then it could have been due to the HRT. Why would you want to take that risk? So that was putting a lot of women off. And there was a lot of uncertainty around the breast cancer risk. So there were a lot of studies being done, and there were one or two which may have not given the right information, and that scared the population into the breast cancer risk being much higher than it actually was. There is a small risk of breast cancer, so we can't dismiss that, but it's not as bad as we think. So there's been a lot of uncertainty around HRT. And as a GP, when I first qualified almost 10 years ago, I was a bit worried about prescribing HRT in the oral form. And then at that time, we had just started to introduce the transdermal form. So that means that the estrogen element goes through the skin, either as a patch or a gel or a spray. And that means there's no risk of clots. So that's been eliminated completely. So it's a lot safer now to take it than it was some years ago.
And the media that probably didn't help either then. Because it must have latched on to that breast cancer, a buzzword, and then that would have exploded. And
not even just media, even doctors were worried, to prescribe it, because it was a bit uncertain back then with the studies undertaken. Even doctors would be probably a bit reluctant to start on HRT. And then there used to be a thing about stopping it by a certain age, so stopping it by the age of 60. But actually now there's not enough evidence to say that we have to do that. In fact, there's a lot of benefits from HRT, so it can continue beyond the age of 60.
So they can carry on till
they wanted to, as long as they're happy with the risks that come with it.
Yeah.
So it gets a little bit complicated with the risks and benefits. Mostly it's benefits, but it just depends on the individual.
And the exercise you were saying, I just wanted so people will know, what exercise should they be doing then for those muscles? So
I think just work on just work on the big muscles. I usually tell women. So, your legs, your arms and your abdomen. And you don't even have to join a gym. You could really just find things on YouTube. It depends on your affordability as well. So you can find things on YouTube for weight training for women and using body weight. Okay,
just
so
do it in the living room.
there's so many things you can do just in your living room without any weights that will strengthen your muscles. But if you did want to work on that, which generally you should try and get stronger, then you would probably need to introduce weights. And gyms are obviously a good idea because they have all the equipment, they have the right trainers, the right classes, and it can help you sort of get involved and find the motivation to do it as well.
Yeah. Since we've gone to the HRT, but I just wanted to do the sleep disruption because it was another symptom.
Yeah.
Is that common?
Yeah, it's really common. So, and that can be a horrible symptom. If you're not sleeping well, you can't function properly the next day. If you've got a job, if you've got your children to look after, if you've got everything that you need to get on with, it can affect a lot of things. So, we don't know why the sleep is affected again with menopause. We don't quite know the function behind it. It's something to do with the fluctuation of the hormones.
Yeah.
But it could also be from the night sweats. So night sweats is quite a common issue, or even passing urine more frequently can be a symptom. So there could be other things that are causing the sleeplessness. But yeah, we don't quite know exactly why, but usually we recommend to women try things like magnesium, or you can even get melatonin, which helps your natural sleep cycle. So they can be things that you try without needing to go onto HRT. But if you did go onto HRT, there's one particular type of the progesterone tablet that can really help with sleep. So that's quite beneficial. But yeah, we don't quite know the mechanism why it happens.
With all the symptoms that we've gone through now, life is hard anyway in general.
Yeah.
At that stage, do you see depression increase during the peri and menopause, maybe not peri, but menopause phase?
Yes, and sometimes that can be misdiagnosed as being, a female going through peri or menopause as being solely depressed or anxious. We as GPs can make that sort of mistake maybe of thinking it is just depression, but actually if you look at the age and if you look at some of the other symptoms, sometimes if you dive in a bit deeper, you can find out that it is probably linked to the peri and the menopause. Having said that, the treatment that we give for depression or anxiety does also work for menopause management and perimenopause management. So that's an alternative to the HRT, the types of antidepressants and anti-anxiety medication. So it's not the wrong treatment to be on, but it's not necessarily replacing your hormones. So it is quite a common symptom though, and it can be multifactorial. It could be from the fluctuation of the hormones and it being linked to menopause itself, but it can also be as a secondary effect of finding life so difficult and everything just weighing you down. So multifactorial for why women can feel low, feel depressed and have anxiety.
And from a male point of view now, how does that affect relationships and especially being intimate? Because that must weigh down. Yeah.
So there's a couple of symptoms actually that I didn't mention. One is it can affect the vagina itself. So vaginal dryness is a really common issue that is not talked about enough amongst women. And sometimes women present much later in life saying they've been struggling for a long time, and it's because of vaginal dryness. So when we lose that estrogen in the female body, that also affects the vagina itself. And if you don't have the estrogen, it doesn't give you any lubrication. It can feel horrible. It can feel really itchy, really dry. It can make sex really uncomfortable. So that's one of the symptoms. That in itself can affect your sexual relationship. The other thing is libido. So libido can also be affected if you are going through peri or menopause, and we often see that too. So that can also affect your relationship. So actually it can affect your relationship for multiple reasons, just how you're feeling, how your vagina is feeling, and your libido. And there are ways to obviously help with that. There's other things to HRT. So with the HRT we've discussed is just a generic form of HRT. But there's also vaginal pessaries, which are really commonly prescribed in all ages, and they're more or less safe for anyone to use. So they're something to know about and to ask from the doctor. And then you've also got the option of testosterone in addition to the HRT. Okay, so it's not licensed to have any other time other than for low libido, but that can really help women. So that's something that's probably not talked about enough, but it's a really important symptom, and it is something we can help with.
I think it's even just the communication between the husband and the wife as well, because she doesn't want to admit that she hasn't got the the libido to
Yeah.
have to be intimate, but she doesn't want to communicate the why,
Yeah.
then the partner is probably feeling left out, thinking she's not attracted to me anymore. What's going on? And that's probably when those arguments happen. When if they just had that conversation and the symptom, they'll be like, it's understandable, really, isn't it?
Absolutely, and it's really common that women will come and tell me, I'm just not feeling like having any sex, and my partner's taking it personally,
Yeah.
because it will affect your relationship. Of course, it will, and it is an important symptom. It's an important part of life to have the libido. So it's not something we should be ashamed of talking about, and for women to come to the GP for if they are struggling.
But leads into the confidence as well, because
Yeah.
the woman doesn't want to admit either that she doesn't want to have sex, or she's enjoyed it for so many years. So that's another confidence drainer as well.
Absolutely. All of these symptoms are. Every single symptom will affect a woman's confidence in some way if it's bothering them enough. So, yeah.
The recent government menopause policy,
Yeah.
how has that impacted women in the workplace?
So I was involved with that policy, and really great idea because we really got the awareness out there. In general, I think Gibraltar has a really good awareness of menopause. So that policy was to try and help women understand what menopause is, because as we've discussed, not everyone knows, not every female knows, but also to help a workplace understand what it is. And that's important because if the symptoms are bad enough to affect a woman's ability to work, she may not be functioning and working to the best of her ability. And this could be someone who is really capable and has a very good skill set, but just can't apply that at work because she's struggling with her symptoms. So if people at work can understand that and just have the sympathy and the compassion towards the female instead of maybe having any judgment or lack of understanding, then it will just help better support them. And also for managers who tend to be more male dominant, won't necessarily understand what this means. So if they have more awareness and they know how to manage it better, then that would hopefully improve their morale, their ability to work better, and help them stay in a job instead of eventually sort of feeling that they need to leave because they're not working to the best of their ability. So I don't directly see the impact, but hopefully it is having
Just having the conversation really about it at work, or admitting that it does affect them at work, probably has already helped so many women now in the workplace, and the future generations as well that are coming up and will go through that as well. So I think the government, what they've done in that policy is really, really good.
Exactly.
And I think we're ahead. Sorry for interrupting, but I think we're ahead, aren't we? Like most places in UK and the rest of the world.
For sure we are. I mean, I've been here for just over 2 years, and we didn't have this level of menopause care in the UK, I feel. I mean, I've learned a lot about menopause management since I've been here, but to have we have a dedicated clinic to Well Women, which I think is amazing.
Yeah.
And there's a lot of doctors, even in the private sector, that know a lot about menopause management. So I think generally it's really well managed here. So that's a good thing. Just going back to the working strategy group with the menopause policy, we have actually started to hold workshops for different sectors.
Okay.
At the moment, they're just government sectors.
It's line managers.
Yeah, to line managers and just the employees to raise the awareness and just talk about how changes can be implemented. Simple changes can be implemented to help a female work better in the workplace management. So we won't necessarily see the impact of that policy immediately. It might take a little while, but we're definitely getting the message out there.
So let me dig a little bit into that one. Is it like teaching the male line managers how to deal with a situation, or is it directing them to a female because maybe the female opens up much easier to a female than to a male? Is that involved or not really? Is it trying to just do everybody?
Well, I mean, sometimes you have no choice. If the manager's male, you may well find yourself having to explain a little bit about what you're going through to a male. So if they have that background understanding, then it does help significantly, because if they're feeling supported and they're in a understanding environment, then that's when they can communicate better and just come to a better agreement on what works for them best. Like, for example, if a female can't quite wake up in the morning because she just has had a terrible night, if her job allows her to have different sort of shift patterns, then maybe working a bit later in the day would be more constructive for her. If she can have a room which is not as cramped or as hot, or no ACs, no fans, that wouldn't be so helpful. So a room that does have the right ventilation, that would help. Clothing, some workplaces have a specific clothing, but actually women need to have certain light clothing if they are having hot sweats.
Okay.
So that's something else to consider. And just having regular check-ins with their manager if they are struggling, if they're taking a lot of time off because of their symptoms, or they're just not working to the best of their ability, then at least they can have those check-ins with their line manager and see what else can be done to help improve things. So there's so many small things that you can implement just to help a female in the workplace.
Even if it's a 15-minute break as well, because maybe she feels overwhelmed in that moment.
Exactly.
They can step out.
Exactly. So yeah, there's so many little things that can be done. But also just giving the awareness to the manager, because I remember in one of the workshops, one of the male managers was asking, well, how can I bring this up with a female? Should I just ask her if she's going through menopause? And actually that's not the right approach.
No, I can imagine
it's not the right approach, because it's quite often that maybe men don't quite understand and will just assume that a female is on their period or something hormonal is going on. And that can sometimes not be the right approach, because it may sort of be invalidating feelings and emotions. So just not jumping to a conclusion.
The old cliche, you're in your period, that's why today you're...
Exactly, so just letting them open up.
With a partner especially, so you're like, today you're bitchy, that's because you're in your period, isn't it?
Yeah, no, I've heard that a lot, so...
Not the right way, no.
Yeah.
For women in their 30s and 40s, what should they be doing to prepare? Because it's coming, so it's probably admitting that it's coming.
Yeah.
And what then should they be doing to prepare?
Yeah, I mean, when we say it's coming, it's not going to be like a tidal wave. It will gradually probably creep up on them without them realizing. But really, we go back to those lifestyle factors. Those are just key. So making sure that you're not drinking in excess. So we've said a limit of 14 units per week, and actually counting how many alcoholic drinks you're having if you are drinking, not smoking, and doing everything you can to stop smoking if you are. So there's loads of stop smoking services available around you, and the GHA being one of them. And exercise. So we've talked now a lot about muscle training. So really focusing on the strength training and getting yourself into a routine, even if it means joining a gym if you can, or getting some kind of trainer or some program in place. Diet, so making sure that you're eating a balanced diet, lots of protein, trying not to eat in excess, and making sure that weight is within a normal BMI, so that's less than 25.
Okay.
And that's really important, because obesity is a big thing we're touching on at the moment, nationally in the UK as well, because obesity is a big problem. I've forgotten now the exact figures, but it's something around 70% of people are overweight in the country, which is huge. It's a lot. So trying to get that weight down is really important, because that is an all-cause mortality as well. Being overweight will lead to all sorts of diseases, bone health, heart health, mental health, so many different domains. So keeping that weight down is really important. And then the other thing we haven't actually talked about on that note is weight loss injections are a big thing.
Ozempic.
Yeah.
Go into it. Yeah.
So they are mostly available privately, because you'd have to meet the criteria to get it under the GHA, which is to be extremely overweight.
Okay.
So mostly it's available privately. So of course that comes at an expense. But so far we're finding it's a good way to bring the weight down. But you need to have all the lifestyle factors in check. So you can't be having very unhealthy lifestyle factors whilst doing the weight loss injection to lose the weight. That's just completely pointless. So you need to make sure you're also weight training and having a healthy diet, so that you can maintain your weight, and maybe just take the weight loss injection for a short period until you can get the weight back down to a healthy range. But that's been really effective. So I think that's quite a good option if you can afford it.
Does menopause ever end, or does it continue throughout the rest of their lives?
Yeah, I mean, I think this is something that women shouldn't be scared about, because the idea is if you are aware of your symptoms being linked to menopause, and you can get the help that you need, then you shouldn't really struggle with it for the rest of your life. It should be controlled. It's really hard to say how long will the symptoms last, because it's like how long is a piece of thread. So you could have no symptoms at all in the best case. You could have, for any reason, had to go through menopause from a really, really young age, in which case, you should be on HRT earlier on to maintain the bone health and all the other benefits that come with it. But I think yeah, it's difficult to say how long will it last, because some women can still have symptoms beyond 10 years, and sometimes it can be after menopause itself. And we don't always know if those symptoms are then definitely menopause or if it's anything else.
Yeah.
So there's ways to manage it. There's medication that doesn't even have to be HRT to manage it, if that is the case. But HRT itself can actually continue, you know, as we said, for a bit longer than we used to think. So if there is someone struggling with symptoms, then HRT can be an option to continue. It's not, there's not really an end date on it.
So, like you said, there's not an end date on it. So there's not like one day you're at the end of menopause, then okay, I finished. That's it, done.
No, it doesn't quite work like that, unfortunately. Yeah, it kind of creeps in, and then it probably just sort of disappears. So it's a very gradual incline and decline.
The media representation, have you seen that improved?
Massively improved. Now that we have social media, there's so many menopause experts, clinicians who specialize in menopause, who are talking more openly about menopause and managing menopause, and just talking about the things that we never used to talk about, like the low libido and the vaginal dryness. So these things are important symptoms, and important awareness. So there's a lot of good social media content. The only thing I'd say is you just have to be a bit careful with who is qualified and who is not, because I find that this may be some things that are some things that are out there, which I do hear that some of the information is not quite factual. I'm not quite sure what qualifications people generally have. So I think just be a bit careful with where you're getting the information from. But as long as they're qualified clinicians, then you're safe to take the information from them.
The GHA has good ones, actually, don't they?
Yeah, so the GHA has recently uploaded a web page, a website now for information on menopause. So that's where we're asking women to go to get all the information they need, and this is all trusted information. It's been checked and verified by clinicians, and that would be a good starting point. That if they do feel they need help, they may not need any help. So they may just want to look at that and think, oh, I'm actually doing okay and I don't need anything. But if they need some help, then they may be able to get all the right resources online. It's really, if you're thinking about HRT, that yes, you would need to go and see a clinician. But that's a really good way of trying to filter out who actually can help themselves, self-help, and who then needs to go and see a clinician. And the reason that's important, because with all this talk about menopause and the raised awareness, it's obviously attracting more women to get appointments with a GP, which obviously we can't accommodate for all of that, especially in the GHA. So we need to now be able to filter, well, who does really need the appointment and who just needs the information, which we have on the website. So that's a really good place to go to as well.
Male point of view again, how can we better support them when our partners are going through this then, from a male side, you think?
Yeah, that's a really good question. I think having the understanding is the first thing. Okay, so today we've talked everything menopause, and hopefully you'll know a little bit more, and any males watching will understand it a little bit better. You can always do your own reading into menopause and how to try and help. It's just the support, the emotional support is really important from a partner, and just having that understanding and not sort of attacking any kind of anything that you don't think is quite right, because a female may be a little bit irrational if she's not in the right headspace. And I think just having a bit of space for your partner and letting them feel better, or doing anything they can to support them and being helpful would be the key thing.
But it's not even a partner, sorry, because it could be your mother as well.
Absolutely, any family member. It could even be a child.
Yeah.
It can be children who are old enough to know that something's not quite right with their mum, or it can be a sibling or a parent. It can be anyone in the family. It could even be friends. It could be like in workplaces, as we've talked about. So anyone who knows a woman well enough can help support them by just understanding and having some compassion.
Last question then. If someone is listening and is not putting off a checkup, I don't want to word it like that, but what would you say to them when the feeling that they're having, they know that they're off? What would you say to them then?
So the first thing, do some reading online, because like we said, there's a lot of resources online to find out more about menopause, and having that background awareness is important. So like we said, the GHA website's really good to try and figure out where you are. So a bit of self-help first, working on those lifestyle factors, which we've talked about. And if you're still struggling and you just think that things are just too difficult, then definitely speak to a clinician. And then you can talk about HRT if that's an option, or anything else if that's an option.
Okay. Dr. Virdi, Thank you so much for your time.
Thank you. That's good.
And it's good that we're getting the message out. See you next time. Thank you for watching.